Hello, we are back from the short break we had, and we are very excited again for the next presentations. Thank you for being there and continuing to listen to our next talks, which is more like organ specific. We are turning from tumor agnostics to more organ specific questions in these almost afternoon sessions and evening in Korea. Welcome, Korea. Dr. Han-Byoel Lee is our next presenter, who is a fascinating surgeon, also taking his time and devotion to cancer diagnostics and improving treatment for women in Korea. So he has worked on adjuvant testing in his past decades, and he has developed with his team in a Korean environment a very specific testing method to guide adjuvant decision making in breast cancer, most of all hormone positive and HER2 negative disease. This test was actually being to some part executed in Hungary in their routine diagnostics, and a wide collaboration has started. So we hope to continue with that in the near future, and we would like to offer the support of the Central East European Academy of Oncology to take this further and investigate these questions in our populations as well. So welcome, Dr. Lee. I really appreciate you are there, and we look forward very much to your presentation.
Thank you very much, Dr. Sass, for your wonderful, kind introduction. Actually, I am not in South Korea right now. I'm in the middle of my sabbatical research year here at UC Irvine in California. So it's actually 2:30 in the morning, but I'm okay. I'm wide awake now. So it's a pleasure to be able to speak here today at this wonderful meeting, learning again from wonderful speakers. So this is my disclosure. I am a co-founder of a company called DCGen, which provides service for the NGS-based Multigene Assay. Briefly, I am a surgical oncologist. I'm a breast surgeon specializing in breast cancer surgery. I'm involved in translational research, developing genomic assays and tools, and also techniques and methodologies for spatial genomics and transcriptomic analyses. In clinical research, I'm deeply involved in de-escalation and optimization of surgery, oncoplastic surgery, and I am the PI of the Optimus trial and actively participating in over 20 prospective studies. So when we look into breast cancer and the clinical decision-making process, we use prognostic as well as predictive markers. These markers, ER, PR, HER2, and also all these clinical factors come into play. And the multigene assay or multigene test really incorporates all of this. So in the first section, we talked about a lot of these multigene panel testing, but mainly they're involved in DNA analysis. So all these pan-cancer somatic panels, hereditary cancer panel, which the following speaker will be talking about, is different from the one that I'll be talking to you about today. It's a test analyzing RNA and multigene and analyzing multiple gene expressions and putting them into an algorithm which derives a score. And then according to a cutoff, we classify the scores into high risk or low risk. In breast cancer, it is very well known now that there is a molecular subtype where according to the subtypes, we can divide those in the categories into very different prognostic groups. And using surrogate markers such as estrogen, progesterone receptors, and HER2, and K67 proliferation marker, we can divide them into 4 subtypes. And for the HER2 subtypes, we do obviously have the HER2 targeted agents, but for the luminotypes, the main therapy is hormonal therapy. However, there is a subgroup of the lumino subtypes where chemotherapy is beneficial. And the multigene assay that I'll be talking to you about today is really trying to discriminate luminal A and. So since 2008, This is the NCCN guidelines from the United States. They incorporate the Oncotype DX, which is the 21 gene RT-PCR assay, into the guidelines. This is a version 2021. It's a 21 gene RT-PCR assay that derives a score of 0 to 100, and according to the score, they are divided into different prognostic groups. They do have a wonderful prospective study trial called the TAILOR-X trial. However, what I'm trying to emphasize today is that it has different results for the younger patients, age 50 and under. So for postmenopausal patients, up to recurrence score of 25, there's no chemotherapy benefit, but for younger patients, there is chemotherapy benefit for recurrence score of 16 to 25. This is also seen in the responder trial, where they looked at patients with 1 to 3 metastatic lymph nodes, where there's no chemotherapy benefit for postmenopausal women, but there is chemotherapy benefit for younger women. So since 2024, this was incorporated into the guidelines, dividing the different themes for postmenopausal and premenopausal women. This is a problem for us in Korea, where in the United States and parts of a lot of the parts of Europe, especially Western Europe, a lot of the patients are in their 60s and 70s. However, in Korea, we still have a peak age in our 40s. And this is US data. Whether you look at white Americans, they do have a higher portion of older women, whereas Asian Americans have a lower portion. They have a higher proportion of younger patients. This is very different from the pattern for other cancer, for instance, colorectal cancer, where it is uniformly higher in older patients. So this was the motivation for development. First of all, we wanted to develop it using the NGS platform, in contrast to RT-PCR. For instance, Oncotype DX, MammaPrint, all the other tests commercially available have to send their samples to a central lab. However, if we develop it using an NGS platform, we can do the test on site if there's an NGS machine and also a chemistry. Also, we wanted to reflect our patients better in Korea and also in Asia, where we do have a higher proportion of younger patients. I'm sorry, some of this is in Korean, but we developed this using from a national grant we got back in 2014. During the 4 years, we collaborated with the College of Engineering and pathologists. So we first had to select a unique gene composition, and then realize the targeted RNA sequencing, which is very common these days, but back in 2014, 2015, we had to go through some, technical issues. And then using the gene expression data, we had to go through these, develop a unique pipeline, and then develop an algorithm. So when we were using this pipeline, we incorporated something called the conserved exon CE panel, where we only use the common area of splice variants from the gene expression transcripts. And also we had to go through the normalization through various tools. And we use the artificial neural network and also lasso method to develop an algorithm. And because we cannot get a hold of the samples from the large prospective data trials, we assumed Oncotype DX as the golden standard and used samples that were tested for Oncotype DX and develop algorithms using these unique genes to develop an algorithm that predicts the recurrence score of Oncotype DX. So we use machine learning in contrast to statistics. They have a general purpose learning algorithm, use them, and they have a little more flexibilities and large number of input variables. And it is used a lot in cancer prognosis prediction. Common inputs are gene expression, drug response, clinical information. Common outputs are susceptibility, recurrence, survival, and drug response. And we go through prepare the data set, split the data set into 3 training, validation, and testing sets. And then we do select the model algorithm to use. and then train the model and pick the best model and evaluate the model with this data. So we first went through, checked the data distribution, which has to be even for the training set and also the validation sets. And then we used the lasso regression, which fit the best within our cohort of samples to predict the recurrence score and develop for the algorithm. So this is the first verification test set where we use the classification analysis and also the regression analysis, and to show that in terms of accuracy, classifying them into risks, it was 91.4% correlated with Oncotype DX, and also a 0.84 Pearson correlation coefficient. And then we had to go through the actual clinical validation using samples with long-term follow-up data. The final data set showed a median of 141 41 months of follow-up. And we used samples that did not receive chemotherapy for all samples that did not develop distant metastasis. And a lot of the samples more than half of the samples did not receive chemotherapy and develop distant metastasis. But in order to include some of the high-risk patients, we did include some patients that did receive chemotherapy, but also did develop distant metastasis. When we look at the ROC curve, it shows an AUC of 0.76 in predicting distant metastasis according to the score of this NGS-based test. This is very comparable to the 0.69 reported for Oncotype DX back in 2008. And I know it's not a direct comparison, but we knew that we were going in the right direction. We had to select a optimal cutoff score of the decision index. This is the name of the score of our test. And when we look at the validation of the clinical data, we can see that it divides very well at a hazard ratio of 5.8 for low risk and high risk scores. Looking at the 5-year distant metastasis-free survival rate, it's 97%, 93%, 77%, 64%. And for the younger patients, the hazard ratio goes up to 7.2, while sustaining a hazard ratio of 4.3. And when we only look at the patients that did not receive chemotherapy, 377 of them, similar results. And the numbers here for the low and high risk patients at 5 and 10 years is very similar to the prospective trial for Oncotype DX, the TAILOR-X trial, and where the survival rates are very, very similar. And according to the decision index, as the score goes up, we can see that the probability of distant metastasis at 5 and 10 years goes up steadily, and this is incorporated into our report system. This is when we look at the younger patients in the no chemotherapy group, the hazard ratio is 9.7, very well discriminative of the prognostic risks, while sustaining a 3.1 hazard ratio for older patients as well. When we compare that to other clinical variables, the C index is very, very high, showing that it is the most effective factor in predicting distant metastasis in these patients. This has led to the commercialization of the test, OncoFree. It is actually the first NGS-based breast cancer prognostic test, and we are providing service in South Korea and in parts of Southeast Asia and also collaborating with Delta Bio 2000, based in Szeged, Hungary. I would like to go back to another test, MammaPrint, developed in the Netherlands. It uses 70 genes for the test. And they also have a very wonderful prospective trial called the MINDEC trial. However, it's the same story. For the older patients, there is no different chemotherapy benefit. In the clinical high, genomic low subgroup patients. However, for the younger patients, there is chemotherapy benefit. Both the TAILOR-X trial for the Oncotype DX, and also the minded trial for the MammaPrint, it is really considered that the younger patients, especially 50 and under, are underrepresented in the development and also the validation trials. Because of that, obviously, this is the American guidelines. They say that for clinically high-risk patients, MammaPrint should not be used. It's a very strong statement. And also, they have this guideline published in 2022 shows for ER positive, premenopausal, postmenopausal women, no negative, no positive. In contrast to numerous tests being recommended for postmenopausal older women, there is a big blank here for premenopausal and younger women. When we look at this Asian versus US population, there is contrasting pathology, ER positive, HER2 positive TNBC, and histologic grade that really crosses at the age of 50 at menopause. And there is contrasting age-specific incidence and pathologic characteristics. We do have a study from Korea looking at Korean patients and the comparison to the TCGA data, showing that we do have a higher proportion of luminal B HER2 positives and a more immune-active microenvironment. Another study from the Yale group, Dr. Putsai, I think he's also from Hungary, showing a lower mRNA suppression of ESR1 and higher expression of immune-related genes in the younger population. And we can summarize that we do, in Asia and also in younger patients, we do have a higher proportion of luminal B cancers, more TP53 mutation, and a more active immune microenvironment. So in contrast to all these tests developed in the West, we do have several tests developed in Asia, including the CureVest from Japan, Recurrendex from Taiwan, GeneSwell BCT also from Korea. However, OncoFree is the only one developed with the NGS platform. Now we also have a prospective trial ongoing for hormone receptor positive negative breast cancer, premenopausal women, 1 to 3 positive lymph nodes. We provide the test OncoFree, and if it is low risk, we forego chemotherapy and offer ovarian function suppression plus AI or tamoxifen, and compare that to the 5-year DFS of the responder trial, which is 96.1%. And we're at about 7 to 8% accrual rate currently. This is very kind of similar to the offset trial going on in the US using the Oncotype DX. And this is actually a RCT trial, and they will be enrolling about 4,000 patients. So I do believe that there's a paradigm shift in the purpose of using multigene assays in breast cancer. Initially, it was developed to avoid overtreatment when we used to give chemotherapy to all of our patients. However, now we know that there is no chemotherapy benefit for a majority of patients, but we do need these tests to avoid missing out on aggressive cancer. Yes, we need some more evidence and more clinical data. For example, in specific topics, for example, ovarian function suppression use and duration, extended endocrine therapy, and neoadjuvant endocrine therapy. So we do have some clinical studies going on, including comparison studies for Oncotype DX, also a study going on in Hungary and here in UC Irvine in California, and also the prospective trials, and also another clinical performance validation test for Korean FDA approval, which all are in submission right now and under review in journals. Briefly, our most recent study looking at 838 patients who were tested for Oncotype DX in Korea. We also went through with the OncoFree test. The correlation coefficient was 0.833, and it's very similar, showing similar AUC, however, better sensitivity and better negative predictive value. And we were able to find more patients who developed distant metastasis within the Oncotype DX low risk population. And hopefully we can get this paper accepted soon. These are some of the future developments. We are developing a molecular subtyping algorithm using the 179 genes incorporated in this onco-free test in collaboration with colleagues in Hungary, including Dr. Saz. And we're going to compare that to the IHC surrogates for subtypes of breast cancer and also PAM50 intrinsic subtypes. Also, we are trying to modify the onco-free. AUC is about 0.75, so it may not be satisfactory. So to improve the test, we are trying to use the multimodal AI-based spatial omics, where we do the spatial sampling according to the active granulation and angiogenic focused morphological evaluation of the pathologic slides using AI and incorporating to a method that we developed called SLACS. So I hope you can look into some of these papers. Briefly, the core technology is the fly-seq. We use infrared lasers to select regions of interest, push the cells into a special from a special glass and put into a tube and go through NGS. Oops. Sorry. Okay. This is an example. We select a region of interest. We just hit the cells, collect them into a tube, and we can do whole genome, whole exome, transcriptome, and also recently we have data for proteomics as well. So we're going to use this to improve the prognostic ability of onco-free. This is my last slide. I really believe that all of these tools that we develop and do research for should be put out in the jungle, in the clinic. And for it to have clinical utility, which means that it affects clinical decision-making, and when we go through the analytical and clinical validity in the development and during the research phase, we need to really incorporate the clinical experience and clinic ideas in the very early phases of development. And I would like to emphasize that. This is my team back in Korea, including my mentor, Professor Won-Shik Khan, and Professor Moon, and Professor Kim, and all the members in our lab. However, I am back in California right now, enjoying my research year and sabbatical. And thank you very much for your attention.
Thank you so much, Dr. Lee, and I'm sorry for missing the location. Welcome, California, then. Thank you for staying up or waking up so early. I see that you have listened to all the talks, so I guess is that you have stayed up all the way along.
So I had a short nap in the evening, so.
I have maybe one question and let you sleep. But we are also happy if you can listen further, of course. So congratulations. It's really like a lifetime achievement the ceremony award as you talk about your results and all these developments all across the globe and with these US hospitals and validating your test further. And I cannot but congratulate you for these efforts. I heard lately that you have reached a further administrative step in Korea with your onco-free testing. So the FDA of Korea, as we would say, has approved the testing. So does it mean anything expansion in that region for the patients? Is that how is healthcare financed in Korea and how patients have access to this specific testing? That's my question, actually.
Thank you very much for your question. Actually, it is still pending. We will get the results of the approval by the end of the year, definitely, and we are very hopeful that it will. If we get the approval, the change is that we can do the test. Currently, we send our samples to Delta Bio 2000 in Hungary, and it takes a little more time. But we can actually go on with the NGS testing in Korea, and within a week, we will have the test results for our patients. And this really affects, the sooner we administer chemotherapy in patients who need them, it will really result in better results, hopefully. And also, the Korean FDA is very notorious for very, very strict regulations. So, and a lot of the authorities globally know about this. So, showing that it has approval from Korea will really hopefully promote services for patients all around the world, and that's really my goal. So, I I do surgery on their patients, but that's a limited number of patients. But if I can, affect patients all around the world through my development, it would be a very, very satisfactory experience.
Thank you so much. I have one question in the chat, and from a medical oncologist who learned about your testing and says that it's very versatile, and is asking whether you have any results for the neoadjuvant setting to predict the therapy response for luminal B type of cancer patients.
Yes, actually, that's a very, very good question and very important one. We do have a prospective trial called NEST, N-E-S-T, that was conducted in Korea, comparing neoadjuvant chemotherapy to endocrine therapy in premenopausal women. So we are now collecting the samples from that prospective clinical trial to go on with the onco-free test and test the chemotherapy response in these luminal B or advanced cancers in a prospective cohort. So hopefully we will go through with this study very quickly and show you the results in the future.
Thank you very much. Thank you for your presentation, and thank you for being with us in this late hour. And we really appreciate your efforts. And as mentioned, the Central and Eastern European Academy of Oncology will foster this understanding and evaluation of your test in this region, hopefully in multiple countries in the near future. So we are looking very much forward to our collaboration in the nearest future. Thank you so much.
Thank you so much.